Welcome back, everybody. This is the first week of this semester for the Biochemical Genetics Clinical Core Seminar Series. It's July 19th, 2024. This is our fifth year, believe it or not, with the biochemical series. And this year there's a couple changes, small changes, but they're there. You'll notice we're not saying medical biochemical genetics. Sorry, Nicola. I should have given you the updated logo. We're being inclusive now for the Clinical Biochemical Genetics Fellowship, as well as the Medical Biochemical Genetics Fellowship. And that is what this series is directed towards. Everybody's welcome to join, but the target is going to be biochemical fellows who are going to be sitting for the Biochemical Genetics Board exam coming up. But like I said, everybody's welcome to join. We have folks on the email server from over 10 different countries, all types of learners. Everybody is welcome to join on Fridays, as well as get to SIMD website and get the archives lectures that are there. They'll be there in perpetuity, as far as I know. Those lectures are available to anyone, regardless of your SIMD membership. I would be remiss if I said we would love your SIMD membership as the member chair for SIMD, but you can have access to the lectures for free without membership at all. So that's simd.org, and you can get to it through the educational links on that website. This year, as always, we have CME offered for anybody who wants to have it. This is through the Children's Hospital Colorado Continuing Education website. And the link Sarah Higgsley just posted in the chat. We'll post it a couple times during the lecture, so you'll be able to access it. You take the code that's in there. It's unique to each week that we have the series per lecture. And if you join live, you can take the code and either text it or get onto the website and enter it for up to 1.5 hours per week of CME credit. So that's all sponsored by educational grant from Ultragenics. We're very happy. This is the third year that we've had this educational grant available, and it goes towards CME. We don't get any money from it. It's completely for you guys to have free CME if you choose to claim it. The only other addition this year is going to be, and this is a great addition, we have through the SIMD Educational Committee webinar series, we've added on CME credit and participation in this series with that series for quarterly case-based discussions. So if you're not familiar with the SIMD webinar series, it's a quarterly 1-hour discussion session, basically, with an expert panel and fellows and trainees presenting cases. It's strictly case-based, but it does tie in very, very well to the content in the series that you'll be hearing through didactics here. As always, you can have questions. I would say probably save them to the end, but if you want to bounce them around in the chat, it's totally up to you. There's definitely chatter that goes on during each lecture, and if there's something important enough or necessary enough for the speaker to address Nicola, I can call out anything that comes up that might be immediate. Otherwise, we'll just save things towards the end if that's okay with you. But all that said, I'd like to introduce Nicola Longo. So Nicola has been giving this lecture and this set of lectures in the series for a few years, and we're so happy to have him. If you'll notice, his affiliation has changed. He had been with University of Utah for a long, long time, and he is now the section head at UCLA. So I want to give a plug in. He's recruiting for positions. If anybody's looking for a faculty position, he has them open, and it's Los Angeles, so wonderful weather and a lot of other advantages to living in the LA area. But I will let Nicola speak to that, and without further ado, I will let Nicola start talking. Dr. Longo, please.
Thank you very much for the introduction, Pete. And yes, I'm at UCLA. We are recruiting for a clinical or clinical biochemical genetic, medical biochemical genetic position here. So feel free to apply. And if you have any question, my email is on this slide. So today I'm going to start my introduction about carnitine and fatty acid oxidation to discuss what it does and why it is important for us. So here are my disclosure, and none of this stuff is probably discussed inside my presentation today. So, but what we want to do, we want to define the role of fatty acid oxidation in fasting and recognize the role of carnitine in fatty acid oxidation and define the principle of treatment of fatty acid oxidation disorder. Now, why do we need fatty acid? We need fatty acid because we don't eat all the time. What we do, usually we eat, and the food is absorbed from the intestine, and this process can maintain the supply of energy to the body for about 1 to 2 hours, just the absorption. And usually, all of the numbers here have a range with the idea that, the smaller number apply to younger and smaller individuals, the larger number apply to older individuals. And then during the absorption phase, some of the sugar will be deposited in the liver in the form of glycogen. There is a limit on how much sugar can be stored in the form of glycogen, meaning that we can put some, but not very much. And that it is why glycogen release can maintain the supply of glucose and energy for another several hours after the absorption phase. Usually it's not up to 8 hours, but about 3-4 hours after eating, it can be sufficient to maintain energy level. At that point, there is a change for which the body starts synthesizing glucose on its own by gluconeogenesis, mostly by the action of the kidney and the liver. And then fatty acid oxidation starts. What happens with fatty acid? What happens is that when we eat, we store some amount of energy in the liver as glycogen, but again, this amount is very limited. The excess energy can be used to synthesize fatty acids, which are deposited in the adipose tissue. And there is no limit on how much fat can be deposited in the adipose tissue. And obviously, when we start fasting, we start burning down the fat and using fatty acid to produce energy. Now, if we didn't have fatty acid to store energy, we would have to eat all the time. Think to bacteria. Bacteria need to be always in a medium containing nutrients. Animals, instead, they don't need that. And if you think to the early human, they went, let's say, hunting for a few days. They found nothing. But they were able to survive. They were able to survive because they had the adipose tissue. Why do we have these changes in energy utilization? We do mostly through to the action of hormones. When we eat, the first thing that we do, we secrete insulin, and insulin causes the deposition of glucose in the body and also the synthesis of fatty acid. And then as insulin level wane, we start releasing glycogen and eventually cortisol. And what they do, they switch from the utilization and the deposition of glycogen and fat to their utilization. And obviously, once we extend the fasting beyond a certain level, ketone bodies become the most relevant source of energy, and this can last for quite some time. At the beginning, glucose is the major fuel for the brain, and eventually ketone bodies become the major fuel. But at any time, the availability of ketone bodies reduces the reliance of the body on glucose, meaning that it can spare glucose utilization. Now, what happened in fatty acid oxidation disorder? So what happened is that fatty acid oxidation plays a major role in energy production during fasting. We don't use much fatty acid oxidation when we are eating. it requires at least 20 individual steps, each one of which may be defective, to cause a fatty acid oxidation disorder. And this step can be mediated either by enzyme or membrane transporter. And carnitine is essential to carry fatty acid inside mitochondria for their utilization. And that it is why we discuss them as disorder of the carnitine cycle and of fatty acid oxidation. And all fatty acid oxidation disorder and disorder of the carnitine cycle are inherited as autosomal recessive traits. Now, what do we do with carnitine? This slide shows a schematic of a cell that is doing fatty acid oxidation. So what happened is that you have seen that fatty acids are stored in the adipose tissue, and under fasting condition, they are released to the general circulation. Fatty acids do not mix well with water, so they are usually attached to albumin or other protein, and attached to them, they reach the surface, the membrane of cell that will utilize fatty acid. This cell has specific membrane transporter that are called fatty acid transporter, and they go with the mnemonic of FATP, and there are many different family, and you know here that we know at least 6 of them. And what they do, this fatty acid transporter, they take the fatty acid and they carry this inside the cell. Inside the cell, to the action of acyl-CoA synthase, fatty acids are immediately conjugated to coenzyme A to form an acyl-CoA. And at this point, the acyl-CoA can have different type of destination. The one which is the most important and the only one that leads to energy production is the one in mitochondria. But if mitochondrial fatty acid oxidation is defective, the fatty acid can go to the peroxisome or mostly to microsome, where they undergo different types of metabolism. And especially in the microsome, they undergo, instead of undergoing beta oxidation, which is the one that occurs within mitochondria, they undergo omega oxidation. Mean that normally fatty acids have a COOH on one end, and they will become a decarboxylic fatty acid after metabolism in the microsome. So there will be a COOH on both sides of the carbon molecule. And at this point, the fatty acid can enter mitochondria through alternative mechanisms, especially after they're being shortened in the peroxisome. But again, usually this type of metabolism occur only if there is a disorder of mitochondrial beta oxidation. And the carboxylic fatty acid, the carboxylic medium chain triglyceride, can be a sign of defective fatty acid oxidation, again, because what happened, they would be shuttled to the microsome and they would appear if you examine them. Now, all of the fatty acids within the cytoplasm usually are conjugated with fatty acid binding protein, which direct the fatty acid for further metabolism. And again, the most important route of metabolism is the one in mitochondria. To enter mitochondria, fatty acid conjugated with CoA need to be detached from coenzyme A because it is a very big molecule. And the molecule that does that is carnitine palmitoyl transferase 1, which is located in the inner aspect of the outer mitochondrial membrane. What this enzyme does, it takes away the coenzyme A and attaches the acyl group to carnitine. And you can see the general structure of an acyl carnitine. So usually you have that the carnitine is conjugated to a fatty acid. If the fatty acid has 16 carbon atoms, this would be called C16. If it is 14 carbon atom, it would be C14. Cell receive carnitine to the action of a plasma membrane carnitine transporter, which is called the organic cation transporter novel 2 transporter, which carry carnitine inside the cell. Carnitine is very concentrated inside the cell. The external concentration is 30 micromolar. Inside the cell can reach millimolar concentration. But again, carnitine will be conjugated to the acyl group, and then you form an acyl carnitine. The acyl carnitine will enter mitochondria to action of the carnitine acyl carnitine translocator, which is a transporter in the inner mitochondrial membrane. So the acyl carnitine will be transferred inside the mitochondrial matrix, and at this point, it will undergo a second reaction with another carnitine palmitoyl transferase, which is called carnitine palmitoyl transferase 2. This enzyme will conjugate the acyl group, the fatty acid, back to the coenzyme A that is now able to undergo beta oxidation. At the same time, this enzyme will release free carnitine, and the free carnitine will be able to go back to the cytoplasm by the action of the carnitine acylcarnitine translocator, which is called an antiporter. It carries carnitine out and the acyl carnitine in at the same time. So carnitine then will be able to start a new cycle. So, but the bottom line is that carnitine is required to bring the fatty acid inside mitochondria for subsequent beta oxidation. And the second point is that if there is a problem with either carrying the fatty acid inside mitochondria or with beta oxidation, the fatty acid will undergo alternative metabolism that might produce other type of indicator of abnormal fatty acid oxidation. Now, what happened in beta oxidation? In beta oxidation, and this is shown for the most common fatty acid, which is C16, which is conjugated with coenzyme A, is a series of reaction beta oxidation in which the long chain fatty acid is progressively shortened by 2 carbon atom at each cycle by the action of several enzymes. The first enzyme is an enzyme that has a specificity for long chain fatty acid, mostly VLK, very long chain acyl-CoA dehydrogenase. This enzyme is a dehydrogenase, so it takes away hydrogen, meaning that it will require the formation of a double bond inside the molecule in this position, and all dehydrogenases are the same. And then the second enzyme is what we call a trifunctional protein. It's called trifunctional protein because it does 3 functions. So first of all, is a hydratase. It has water to the fatty acid, and you see the presence of an hydroxylated acyl-CoA here. The second reaction is a dehydrogenase. You take away hydrogen and you introduce a double bond between this carbon here and the oxygen. So at this point, you have ketones, and then you split this ketone by the action of a thiolase by adding another molecule of coenzyme A. This last reaction will generate acetyl-CoA with the last 2 carbon atoms, and also a acyl-CoA, which is shorter of 2 atoms. So you shall start from 16 and you finish at 14. And then this fatty acid will be able to start another cycle. Once it is short enough, it will become a substrate of another enzyme. The second one important is the medium chain acyl-CoA dehydrogenase deficiency. And when it is short enough, it will become a substrate of the short chain acyl-CoA dehydrogenase. Now, please notice that there is overlapping specificity of this enzyme. So it's not that there is a single substrate of each enzyme. I mean that, in physiological condition, when the system is not stressed, one enzyme might help deficiency of another enzyme. But it is no longer the case when the body needs energy only from fatty acids, such as during prolonged fasting. Now, what do we do with this type of beta oxidation? We can do two things. In the liver, usually once we get to the formation of acetyl-CoA, two molecules of acetyl-CoA can be combined together to form ketones. And this ketone can be utilized can be released by the liver and be provided to every tissue in the body. At the same time, there are organs such as the skeletal muscle and the heart that can do a complete oxidation of the fatty acid to produce energy by shuttling the acetyl-CoA inside the tricarboxylic acid cycle. So two types of final outcome: production of ketones, mostly in the liver, full oxidation with production of CO2 and water, and obviously energy. So this is what happened during beta oxidation. Now, what happened if fatty acid oxidation is defective? If fatty acid oxidation is defective, is that during fasting, fatty acid will still be released from the adipose tissue. Again, in physiological condition, they reach the liver, they produce ketones. Ketones can go to all organs, including the brain. The utilization of ketone will spare the utilization of glucose, so usually people do pretty well when that happens. Fatty acid can also go directly to the heart and the skeletal muscle, where they can be utilized for energy production. Now, what happens if the fatty acid oxidation is defective? Fatty acid, again, they're still released from the adipose tissue. They can reach the skeletal muscle and the heart, where they will accumulate and cause organ dysfunction. In the muscle, they can cause myopathy, low muscle tone. Sometimes they can cause muscle breakdown with rhabdomyolysis and myoglobinuria. In the heart, they can cause cardiomyopathy, or they can cause sudden arrhythmia with sudden death. And in the liver, they can cause liver steatosis, and they will also result in decreased production of ketones. So disorder of fatty acid oxidation can cause hypoketonemia. At this point, the body will utilize all of the glucose, and there will be hypoglycemia associated with hypoketosis, or what we call hypoketotic hypoglycemia. If there is no glucose and there are no ketones, the brain will have no energy to function and can suffer loss of consciousness, leading to coma and possible death. So basically, these are all of the symptoms that we can see in fatty acid oxidation disorder: hypoketotic hypoglycemia, cardiomyopathy, arrhythmia, steatosis of the liver, rhabdomyolysis, and other problems that we will see in a second. Now, what happens if a patient dies during an episode of during an acute attack? If you do a biopsy of the liver, you will see that there will be a lot of fat accumulated in the liver. All of these white bubbles, they represent fat that has been accumulated inside the liver. And you can observe both micro and macro vesicular steatosis inside the liver. You can see that to a lesser extent in the heart and the skeletal muscle. It is present there as well, but to a lesser extent. What you see the most, you see the depletion of glycogen, and the right portion of the slide show glycogen staining using paths. And the blue accumulated stuff is glycogen. You can see that in normal condition, there is a lot of glycogen inside the liver. Even after the end of fasting, there is still some residual glycogen. In the liver of a person with a fatty acid oxidation disorder, there is no more glycogen. There is no more blue that you can see. And you see the same in the heart and the skeletal muscle. You can see that there is a residual glycogen in normal individual. In people who have a fatty acid oxidation disorder, you see that the glycogen is totally gone. So, and that it is why these people crash. There is lack of energy, but most importantly, there is the accumulation of toxic fatty acids. So the toxicity depends both on the lack of energy and the accumulation of toxic chemicals that are derived from fatty acids. So in general, most fatty acid oxidation disorders are silent and are triggered only when energy from fasting is necessary, when the fat will be released from the fatty acid store, from the adipose tissue. And triggering conditions include fever, because when people have fever, they have an increased energy requirement, and also they have they do not want to eat. When people have a fever, they are not hungry. Gastroenteritis, vomiting, or any condition in which there is a reduced caloric intake. So children usually present shortly after birth, mostly with initiation of breastfeeding, because the first milk that it is produced is not very rich of energy. And the second time, sometimes it's hard to produce enough milk, or at any age during an illness causing catabolism. And this can also occur in adult age. There have been people that have presented with fatty acid oxidation disorder at 40, 50, and 60 years of age. So this is a summary of all fatty acid oxidation disorder. So it can be caused by deficiency of any of 20 enzymes. The most frequent is medium chain acyl-CoA dehydrogenase deficiency, which has a frequency of about 1 in 10,000. All other are much more rare. The pathogenesis is caused by the accumulation of fat and toxic metabolite, lack of energy, the depletion of coenzyme A, and cell death. And on autopsy, there can be fat infiltration of all tissue and glycogen depletion. The presentation can include fasting-induced hypoketotic hypoglycemia, liver failure, hyperammonemia, what we were calling in the old day Reye's syndrome, cardiomyopathy, there can be myopathy, hypotonia. Some conditions also present with neuropathy or eye finding. There can be arrhythmia, sudden death, and rhabdomyolysis. The diagnosis depends on the measurement of plasma carnitine, free and total, and plasma isocarnitine profile. Urine organic acid, even though they were used more in the past, not anymore today, and they're usually informative only during acute attack, the urine organic acid. We use the measurement of free fatty acid to differentiate from other causes of hypoglycemia, but the mainstay of therapy are DNA studies that can test different genes. Sometimes we find VUSs, variant of unknown clinical significance, for which we need additional testing consisting of in vitro probe, enzyme assay, or transporter assay. What is the therapy? The number one therapy is avoidance of fasting and the prompt treatment of infection or anything that prevents people from eating. Some of these conditions require a low-fat diet. Many of these conditions, especially disorder of long-chain fatty acid oxidation, require the use of medium-chain triglyceride or triheptanoid, that it is a little bit more effective of MCT oil. Some conditions cause carnitine deficiency and they require carnitine supplementation. And a condition in which we give a very low-fat diet, usually we give essential fatty acids that might become low in patients who are not supplemented. Let's see a second, why do we use medium-chain triglyceride and triheptanoid? We use that because a condition in which you have defective oxidation of long-chain fat, either because there is a disorder of the carnitine cycle with deficiency of CPT1 or CPT2 or CACT, or long-chain fatty acid oxidation disorders such as VLCAD or LCHAD or trifunctional protein deficiency, medium chain triglyceride can be metabolized completely normally. And what happened also is that this medium chain triglyceride can enter mitochondria independently from the carnitine shuttle. As a result, when you give them, they can enter the cell and feed directly into the beta oxidation spiral and then to the Krebs cycle to produce energy. So that it is why they are very effective. What is the difference between C8 and C7? Again, C8, 8 carbon atoms, C7, 7 carbon atoms. Every cycle of beta oxidation will remove 2 carbon atoms. So you go from 8 to 6, from 7 to 5, and then you go from 6 to 4, and from 4 to 2, and then to 0. But here you will go from 7 to 5, 5 to 3, and then the 3 carbon atom is propionyl coenzyme A. And this will be able to be metabolized for propionyl-CoA carboxylase and enter the Krebs cycle. So the advantage of this type of reagent is not only provide energy in the form of acetyl-CoA, but also can provide an intermediate of the Krebs cycle, and some of them might become defective in fatty acid oxidation disorder. So this is your first class in biochemical genetics, and I want to make sure that you understand what we mean by C0, C2, C3, and so on. Again, this is the number of carbon atom that it is attached to free carnitine. And free carnitine is called C0. C2 means that you have acetyl carnitine attached to free carnitine, C3 propionyl carnitine, and so on. If you have C3DC, you have 3 carbon atom decarboxylic. And this is what you have attached to the free carnitine. So anytime that you see this type of nomenclature in this way, you know what you are dealing with. Now, let's go back to a moment to disorder of fatty acid oxidation disorder. So you have a kid that presents acutely to the hospital with a suspected fatty acid oxidation disorder, and you might not even know what is the specific fatty acid oxidation disorder. What do you do with that? What you do with that, you need to provide energy in the form of sugar, and usually many of these children are vomiting or they are unconscious, so you cannot use the enteral route. If you can use the enteral route, obviously you put down an NG tube and you provide calories. But if you cannot use an enteral route, you put an IV and then you provide D10 or 10% glucose plus electrolytes. We use about 75 milliequivalent per liter of sodium chloride in younger individual, and after age 4 to 5, depending on the size of the baby, we switch to normal saline, which is 154 milliequivalent per liter of sodium chloride, and you add proper potassium salt once you are sure that the potassium is normal in the child. You give about 1.5 maintenance, which is 150 milliliters per kilogram per day. So keep in mind that this type of therapy will not provide sufficient amount of calories. As soon as you can, you have to put down an NG tube or start feeding by mouth. At the same time, you obtain a routine lab that consists of electrolyte, liver function test. The creatine kinase, CK, is important to determine if there is muscle involvement and how bad it is. Plasma ammonia, you do a urine analysis to determine if there are ketones or not. And then you do labs and imaging studies to identify the cause of problem that are mostly infection, including culture and X-ray. And then you start enteral feed as soon as possible. I've had a long-term interest in this condition, but the kid that started my interest was this one who presented at 8 months of age with frequent infection and vomiting, and that fever as well. So, and he was admitted because he had low oral intake and became lethargic. He was found to have hepatomegaly and to be lethargic on exam. And laboratory testing indicated non-ketotic hypoglycemia, hyperammonemia, and elevated liver function test. So the urine organic acid had a mild decarboxylic aciduria, plasma amino acids were completely normal, and he improved with intravenous fluid and glucose and was sent home on a low protein diet. They didn't have the result of the plasma amino acid at the time that he was discharged. They sent him back on a low protein diet because he had the elevated ammonia. So he was sent to see us with a diagnosis of Reye's syndrome. What we found was that the plasma carnitine level in this patient were very low. So the total carnitine was 1 and the free carnitine was 1. And you see the normal range below. So the normal of free carnitine is 24 to 56. So obviously what we suspected was a primary carnitine deficiency. At the time, there was no DNA testing because we didn't know the gene, and also there was no functional assay. So we developed an assay to measure carnitine transport, and we confirmed that this child had what we call carnitine transporter deficiency or primary carnitine deficiency. This disease is relatively rare in the US, even though a lot of it is missed by newborn screening. It's very frequent in the Faroe Islands, we will see in a second, but also in China, where 1 in 20,000 people have primary carnitine deficiency. So, and there is a lot, a large number of the human population is present exactly in that area of the world. It's caused by a deficiency of the carnitine transporter. And what happened here is that carnitine is filtered by the kidney and lost in urine. As a result, it disappears. And then when cells don't have enough carnitine inside their cytoplasm, they will become unable to move fatty acid to mitochondria. The presentation is the one that you have just seen with hepatic encephalopathy, hypoglycemia, cardiomyopathy in children, but they can present with sudden arrhythmia or exertional rhabdomyolysis in adults, and can present with sudden death at any age, children and adults. How do we diagnose it? There is very low plasma carnitine, usually before 5 micromolar. I'm sorry for the typo, it should be micromolar, not millimolar. It can be higher in newborn, and then there is decreased urinary carnitine reabsorption. It is confirmed by DNA testing or transport studies in fibroblasts. And this can be detected by newborn screening. The therapy consists in carnitine administration. The dose is up to 100 milligrams per kilogram, but the max dose is about 3 grams per day. What happens is that there is a limit on how much carnitine can be absorbed by the intestine. If you go above 1 gram per dose, then it will cause diarrhea. In addition, carnitine is metabolized to trimethylamine. Trimethylamine is the one that causes the smell of rotten fish. So basically, if you give too much, people have diarrhea and they smell like rotten fish. And also the level of carnitine does not increase further in plasma because it is just lost in the stool. And that it is why we limit the dose to a certain amount. The goal of the therapy is not to normalize the carnitine level, but to get measurable level of carnitine, something like 10, 15 micromolar, so that it is usually enough to prevent symptoms in this patient. The only thing that we can do, we can give an extra dose if the level are still too low. So we still stay low to 1 gram per dose max, but we can give 3, 4, 5 doses if necessary. We now monitor plasma carnitine free and total, and the prognosis is excellent with therapy. Now, what do we see in a patient with this condition? You can see that at diagnosis, the level of carnitine, of free carnitine is very low, like 3, and then you start going up on the level as you start supplementation, but they still remain below the normal range. Now, what happened? This transporter is expressed in all organs and tissue, including fibroblasts, and you can see that carnitine transport in fibroblasts from this patient is markedly reduced as compared to fibroblasts from control. Now, primary carnitine deficiency can be identified by newborn screening. How? The gray is the normal range for carnitine level in newborn, and you can see that this infant can have low level of carnitine. However, many of them can have very normal level of carnitine. Why? Because the level of carnitine in the baby depends on the level of carnitine in the mom. The carnitine is transferred from the mom to the baby through the placenta. Means that if the mom has a low carnitine, the baby will have very low level of carnitine. And what happened that many of the babies that we identified the mother who have primary carnitine deficiency. Mothers who have been usually relatively asymptomatic up to that point. And obviously, if the baby does not have carnitine, as soon as we start carnitine supplementation, the carnitine levels spike very high. Instead, babies who have primary carnitine deficiency might have normal carnitine level at birth, and then if you do a second screening, they might fall below the cutoff. So this baby can easily be missed by newborn screening. In the United States, there are states that do only one screening, usually very early in life, and other states that perform two screenings, one early in life and one later on. And obviously, if you don't do a screening later in life, these children can more easily be missed. But let's go back a second to the problem here. We have mothers that seem relatively asymptomatic. Do we need to treat them? And we will see that in a second. But let's go back a moment to see what mutation can cause this disease. So usually we identify most mutation by genetic sequencing, but one has to keep in mind that one of the frequent mutations that explain about 20% of the allele is a mutation in the 5' region of the gene. And this mutation, what it does, it introduces another start codon 5' to the wild type initiation site. If the transcription machinery starts here, then you have a problem. If the translation machinery starts here, then you have a problem. Why? Because this places the wild type initiation site out of frame. And this results sometime in RNA degradation, sometime in an abnormal protein, sometime you skip to a subsequent methionine initiation site. So, but the net result is that this basically reduces the formation of carnitine transporter. It is important to know this because some sequencing labs do not test for this variant, and that it is why this might be missed when you do genetic testing. But let's go back a second to our mothers who have babies and they're being relatively asymptomatic. Are they safe? We do not think so. And what happened many years ago in the Faroe Islands, again, which is the place where this is very frequent, there were many young adults who died in their 20s and 30s of sudden death. And people couldn't figure out why, because they were healthy people. But they were found to have very low carnitine level, and they had primary carnitine deficiency. And then what they did, they screened the population, and they found that the prevalence of primary carnitine deficiency decreased as people got older. At the beginning, 1 in 300 had the disease. At the end, less than 1 in 50,000 had this condition. And in between, people just died. And since they died of sudden death, this did not trigger any type of further investigation. So basically, there is a very high risk of sudden death in people who have primary carnitine deficiency. And this risk does not go away as people get older. And the most common mutation, we identified this one in a patient with long QT syndrome. And this patient started doing perfectly well after starting carnitine supplementation. In addition, in the Faroe Islands, after they started carnitine supplementation of people identified with this condition, there has been no more health issue in people with primary carnitine deficiency. So people with carnitine deficiency can be completely asymptomatic, but they are at risk of sudden death if they don't take carnitine. And in general, this episode of sudden death follow an episode of an upper respiratory tract infection, fever, or any use of antibiotic, or any other problem that can increase utilization of fatty acids. Now, when you go to the ACMG website, there are algorithms that tell you what to do in case you have abnormality of a specific marker. What do you do if you have a decreased free carnitine? So obviously, you measure plasma free and total carnitine and urine free and total carnitine. Why? Because if you measure urine free and total carnitine and creatinine as well, you might be able to determine the carnitine reabsorption by the kidney and determine if the patient has primary carnitine deficiency or not. And you need to do this testing, both in the child and in the mother, because the mother might have primary carnitine deficiency. There are other maternal conditions that can cause low carnitine level. And these include maternal 3-methylcrotonyl-CoA carboxylase deficiency, maternal medium chain acyl-CoA dehydrogenase deficiency, because both of these conditions are associated with depletion of carnitine that it is conjugated with the abnormal fatty acid or organic acid. And cystic fibrosis can cause generalized malabsorption with obviously the malabsorption of carnitine. So this is the first disease of the carnitine cycle. What is the second one? The second one is carnitine palmitoyl transferase 1A deficiency, which is very rare, except in the Alaskan population where it is relatively frequent. What happened that here, carnitine cannot conjugate with fatty acid, and so fatty acid cannot not enter inside mitochondria. There are different isoforms of CPT1, and CPT1A is expressed only in the liver and a few other tissues as well, but at a lower level. And most of the symptoms of CPT1A are based in the liver. So you have hepatic encephalopathy, as we have seen in the kid with carnitine deficiency, hypoglycemia, liver failure, and failure to thrive. These patients are the only one who have elevated carnitine level at birth. And since the carnitine cannot be conjugated with long-chain fat, they also have low C16 and C18 carnitine with an increased ratio between C0 and C16 plus C18. Free carnitine, however, can be normal or high in plasma. What it means that you find this consistently elevated in the blood spot. In blood, it is always there, but it is not always there in plasma. So you rely more on the blood spot in this condition than on the plasma. And you confirm the diagnosis by DNA testing, and again, this can be detected by Dumbo screen. Therapy consists in fasting avoidance, and then you lower the content of fat in the diet, but most importantly, you give medium chain triglyceride that can enter the cell independently of the carnitine cycle. You monitor the liver function test, glucose and the glycosylated hemoglobin, which is a long-term indicator of hypoglycemia. The prognosis, we don't have many data, but they do relatively well with therapy. We have now almost adult that, they look pretty normal overall. Now, I follow 2 patients with the classic isoform, and both of them have failure to thrive, and one who was not compliant with therapy also had some type of complication, mostly with seizure because he developed hypoglycemia. The one above instead is doing relatively well and starts growing very well after introducing medium chain triglyceride. What do you see in the acylcarnitine profile and plasma free and total? You can see that everything looks normal. You have to keep in mind that there is no low cutoff for the long chain acylcarnitine. So they are called totally normal, but if you look at all of them, you see that most of them are 0. It is something that you have to look up personally to figure out what it is. Now, there are patients who have milder variants of this condition. One is prevalent in Alaska. In Alaska Native, a good percentage of babies are homozygous for a common variant that retains some residual enzymatic activity. A second variant is very prevalent in Australia and the Marshall Islands. And we know this because we had a lot of people from the Marshall Islands when I was in Utah. And what happened with this condition, you reduce the activity of the enzyme, but usually they never present with hypoglycemia. They do not require any therapy. They seem to have an increased risk of complication for respiratory infection. And we do not know why. Possibly they have an increased risk of pancreatitis, but again, usually it is a benign condition that does not require it. Now, what do we need to do if the C0 is elevated in the newborn screening? The algorithm from ACMG calls for getting plasma level, and we need to do plasma level. But again, even if it is normal, you need to do DNA testing to exclude CPT1 deficiency. You cannot exclude CPT1A deficiency just by doing plasma quarantine-free and total. The second thing, there is a second condition that can cause low quarantine level, which is a deficiency of coenzyme A synthase. And what happens in this condition, you have low coenzyme A. If the fatty acid cannot conjugate to CoA, then it cannot conjugate to quarantine, and you have the same effect on quarantine level. This condition is way more severe because these children tend to have a lot of involvement of their brain. For completeness, deficiency of CPT1B, we do not know that in human. In mice, it is expressed in the heart and the skeletal muscle, and if you do a homozygous knockout of this gene, you don't have viable mice. CPT1C deficiency, it is associated with a dominant condition, which causes neurological presentation, which is autosomal dominant spastic paraplegia number 73. We do not know exactly the mechanism. They believe it may affect the lipid composition in the brain and then, obviously affect the way that people behave. Now, this is another patient that I had many years ago, and this is a child who presented immediately at birth with hypothermia, desaturation, low blood pressure, and severe hypoglycemia. He had a history of a girl who died at 3 days of life, and they didn't know why she died. The child developed tachycardia and bradycardia, but obviously suffered. He had a cardiomyopathy when they did an echo, but he suffered cardiac arrest immediately. Thanks God he was with the cardiologist, so they started doing chest compression. It required 5 minutes of chest compression. Then he started doing okay. He had mild hyperammonemia, increased liver function test, and mild increased CK. So he started on IV glucose with stabilization. This condition is also very rare, and you can see that there was a high degree of consanguinity in the family of this child. So this child has acid-carnitine translocase deficiency, which is a deficiency of the inner mitochondrial acid-carnitine translocator, and results in the accumulation of long-chain acylcarnitine, long-chain fatty acid, and defective energy production. Present with arrhythmia and cardiac arrest, hypoketotic hypoglycemia, and cardiomyopathy. You have an elevation of C16 of the long-chain acylcarnitine, C16, C18, C18-1, C18-2, and usually you have low free carnitine in patients with this condition. The organic acid can be abnormal with a decarboxylic aciduria, and this condition can be identified by DNA testing. Many children with this condition present even before you have the result of the newborn screening back, sometimes even before obtaining newborn screening. Therapy with fasting avoidance, low-fat diet, medium-chain triglyceride, and many of these infants benefit from triheptanoid. And they also receive low-dose carnitine supplementation. You monitor the isocarnitine profile, carnitine free and total, the creatine kinase, and the liver function test. The prognosis is not always good, but there are teenagers with milder variants who have been doing relatively well. Now, how does the isocarnitine profile look like? And this isocarnitine profile actually was obtained even before we started doing that. So even before it was a standard practice. You can see that in a normal isocarnitine profile, you only had pretty much internal standards that are indicated with a star. In this patient, you have the appearance of this long chain isocarnitine. And what happened with therapy with MCT oil, you see that the long chain isocarnitine go down and the free carnitine goes up, and this improves pretty much the outcome of this patient. So this condition present immediately at birth, but there are disorders of fatty acid oxidation that present much later on. And this is a 78-year-old man who had history of persistent muscle cramps with myoglobinuria. He was not able to run or participate in sustained physical exercise since he was a teenager. But then, at one point, he developed diabetes. Diabetes does not have an increased incidence in patients with fatty acid oxidation disorder, but it has, it is very prevalent in our culture. And at that point, with diabetes, he started developing muscle pain and myoglobinuria even without exercise. And this is an isocarnitine profile of this gentleman. And you see that the same isocarnitine that you have seen elevated before are elevated in this patient. The only difference that the free carnitine actually was normal in this patient. It was low in the previous patient. What does this patient have? So this patient had carnitine palmitoyl transferase 2 deficiency, which is very rare, except for the myopathic form, which is still rare, but with several reported cases. I was following about a dozen patients with this condition. So the deficiency of CPT2, what it impairs the transfer of long-chain fatty acid from carnitine to the coenzyme A and prevent mitochondrial beta oxidation. And usually this leads to defective energy production, and there are different types of conditions depending on the degree of enzymatic deficiency. If you have the complete deficiency of this enzyme, you have the lethal neonatal form, in which patients sometimes even have congenital anomalies. They cannot produce energy, the cell die, you have cysts, sometime in the liver, sometime in the brain. And then you have an intermediate form where patient can have respiratory failure, liver failure, cardiomyopathy, arrhythmia, and hypoglycemia. Well, sorry, this is still part of the lethal neonatal form. And again, they do not survive usually beyond a few months of age. And then you have the severe infantile form, where they can still develop cardiomyopathy and hypoglycemia and seizure and sudden arrhythmia. And then you have the late onset, which is the most frequent, the one that we have seen in our patient in the 70-year-old man, where people tend to do well, and then they first start developing muscle pain with exercise, usually when they become teenager. Why when they become teenager? Because when they become teenager, they develop the muscle. The muscle require a lot of energy, and that's when they become symptomatic. The diagnosis is done by finding elevated long-chain isocarnitine in plasma. It can be confirmed by DNA testing. It can be identified by newborn screening, but most cases, especially of the milder variant, are missed by newborn screening. We still do not know what to do to pick them up. What is the therapy? The therapy is fasting avoidance. You give MCT oil, 3-heptanoid, and sugary drink with exercise. And you monitor the usual, which has liver function, the creatine kinase addiction to metabolic lab, and the myopathic form is compatible with long life. So the gentleman that I just told you about eventually died of complication of diabetes after age 90. So he didn't die because of CPT2 deficiency. Keep in mind that I have people with this condition who are competitive athletes. What they need a strict regimen of management to be able to have energy drink and sometimes, in most cases, MCT oil before and during the exercise. This is the algorithm for elevated long-chain isoquantin from the ACMG, and you can notice very well that you cannot distinguish between CACT and CPT2. You have to do genetic testing to distinguish 100% between the two. And that it is, and we need to do panel DNA testing that has substituted completely enzyme S in fibroblast for the diagnosis of this condition. Again, the late onset variant of CPT2 deficiency is usually missed by newborn screening. Now, you will see that many of our long-chain fatty acid oxidation disorder present with this myopathic presentation, so muscle-induced rhabdomyolysis. There are also other conditions that present with muscle-induced rhabdomyolysis. So some of the most frequent one is myocardial disease, which is a glycogen storage disorder. Many other fatty acid oxidation disorder, possibly myoadenylate deaminase deficiency, many mitochondrial disorder, anesthetic-induced malignant hyperthermia. One of the most common causes are autosomal recessive lipin-1 mutation, or any of the other 129 causes. That it is why what you need to do when you have this condition, you do biochemical testing and you get a DNA panel to include all of these conditions. So what is the most common finding? This is a child that I had many years ago, that the kid actually did well after birth, went home from the hospital, and then the child started becoming lethargic and came back to the hospital at 36 hours of life. And the mom was breastfeeding. So the child appeared dehydrated, was given a bolus of normal saline, and the child was found to have low blood glucose with hypoglycemia. And this child has MCAD deficiency. The frequency in the US is about 1 in 18,000. In Utah, it is much higher because this condition is more prevalent in Caucasian, and Utah has a lot of Caucasian population, more than the remaining of the United States. It is caused by mutation in the gene encoding for the medium chain acyl-CoA dehydrogenase, and it is characterized by fasting-induced hypoketotic hypoglycemia, coma, and sudden death. And patients are totally normal between episodes. And many cases can remain asymptomatic until adult life, and they can still suffer sudden death. And some cases present at birth. So the diagnosis is by obtaining a plasma isoquantin profile that causes a consistently abnormal plasma isoquantin profile with elevated C8, C10, and C10-1 carnitine. The urine organic acid shows the presence of hexanoyl glycine. It can be confirmed by DNA testing. The mainstay of therapy is avoidance of fasting and prompt treatment of infection. Some centers recommend a heart-healthy diet after age 1, and many centers give carnitine supplement, which is not proven, but they can develop severe carnitine deficiency. We monitor carnitine level and the isoquantin profile. And the prognosis is excellent with treatment. So the main thing is to avoid fasting. And at birth, obviously, people do not know that the child has MCAD deficiency. And if you push breastfeeding and the breast milk is not coming, they really can suffer irreversible complications. I follow more than 100 children with this condition, and basically the one who suffer complication, they all suffer them before the diagnosis. One infant died at 48 hours of life before the newborn screening was back, and the other had complication related to the fact that the mother wanted to breastfeed and they had not enough milk. So I'm all in favor of breastfeeding, but one needs to be reasonable. If it is not coming, one needs to try supplementing with something else. So the enzyme, again, has this specificity, that it is why C8 is elevated, and usually C8 carnitine, octanoid carnitine, is the one which is the highest, with lower elevation of C6 and C10-1. And if you look at all cases, you see that usually there is a triangle between the C8, the C6, and the C10-1, with C8 being the tip of the triangle. And you can see the excess of hexanoyl glycine and suberyl glycine in patients with this condition. As they get older, phenylpropyl glycine can also appear. This was the initial cause of carnitine deficiency. The very first patient described with carnitine deficiency had indeed MCAD deficiency. What do we need to do if we have an elevation of C6, of C8 in the newborn screening? We do plasma isocarnitine and urine organic acid, and then you can get confirmation of the diagnosis. In general, you do not need DNA testing. We still do to be sure 100%. And also there are some cases where the elevation is only mild, and you really need to do DNA testing to determine if they have it or not. This is a different patient that they had a few years ago, that it is an 8-year-old female who was hospitalized after being unable to move or wake up completely. She couldn't wake up well, and she was admitted to the intensive care unit. She had cardiomyopathy with low cardiac ejection fraction and elevated CK and cardiomegaly on chest X-ray. When you look at the plasma isocarnitine profile, you see that the highest level is found with this one. Well, actually, this one is higher a little bit, but you know. And but the one which is actually the highest level is this one. Sorry, I went too far. Which one is this one? You move to the side, and it is C14-1 carnitine. So this condition is VLCAD deficiency, very long chain acyl-CoA dehydrogenase deficiency. And even here you have different degree of severity depending on the mutation that the patient had. The more severe form usually can present with cardiomyopathy, usually present either at birth. In most cases, it appears a little bit after birth. You have milder variant with hypoketotic hypoglycemia, which is more similar to MCAD deficiency with increased liver function test and elevated CK. And then the most common form is stress-induced rhabdomyolysis, like myopathic CP2 deficiency. All of these patients have a risk of sudden death if fasting is very prolonged. The diagnosis by plasma isocarnitine profile, but this elevated C14-1 can normalize very rapidly if one gives IV fluid, if one gives IV glucose, if there is no stress. And that it is why all patients with an elevated C14-1 carnitine need DNA testing to exclude VLCAD and other fatty acid oxidation disorder. So keep in mind that C14-1 can be elevated not only in VLCAD, but in other fatty acid oxidation disorder. Therapy is avoidance of fasting. Many of these patients require MCT oil and triethanoin. Some of them most of them require low carnitine dose. Remember, we were using 100 milligrams per kilo in patients with primary carnitine deficiency. We go down to 25 because they can develop carnitine depletion. You monitor the usual, and the prognosis can be very good with therapy. So this is just to show what are the liver function tests and the CK in this patient. You can see that they can be persistently elevated. But the important point here is that when you have elevated CK, the ALT and AST can come from the muscle. There is a direct correlation between ALT and AST and CK. And obviously, it is not because the liver is involved here, it's because the ALT and AST are released by the muscle, not by the liver in this case. There can be liver involvement as well in this condition, but you need to do a gamma GT or have other elements that tell you that there is liver involvement before feeling that there is liver involvement in this condition. And you can see that the CK can become pretty high in this condition. So what happens if the C14-1 is elevated? You do a plasma cell content profile, but then you do also DNA testing. And in fact, what you show here is that the plasma cell content profile, if it is normal, you still do the VLCAT gene sequencing. I would recommend doing a fatty acid oxidation disorder gene sequencing. Why? Because again, C14-1 can be elevated with other diseases, not just VLCAT. So, and that it is usually what we do. Here they also suggest functional study. They're usually required if you find a variant of unknown clinical significance and you want to figure out what it is. And the enzyme assay is available actually in white blood cell and actually the University of Colorado in Denver. The other disorder of long-chain fatty acid oxidation is called trifunctional protein deficiency and long-chain 3-hydroxyacylcholine dehydrogenase deficiency. They are both part of the same protein. What is the difference? Is that in L-cell deficiency, you have more impairment of one of the three functions of the trifunctional protein, and that it is why it's called L-cell. It is relatively rare, and the trifunctional protein deficiency can be caused by mutation in either the enzyme is composed of two subunits. You can have mutation in one of the genes encoding either subunit. This patient can present with intrauterine growth restriction prematurity. Why? Because this condition can affect the growth of the baby. And the other thing, the mom can become sick, and that it is why they can be premature. And then, if not identified at birth or by newborn screening, they can present with fasting-induced vomiting and hypoglycemia. Cardiomyopathy can be prominent, and hepatocellular dysfunction and sudden death. There can be rhabdomyolysis, but there are some specific findings in this condition. One is retinitis pigmentosa, and many patients, especially with L-cell deficiency, will develop it with time. Neuropathy. This is more prominent in patients with trifunctional protein deficiency. Some of the initial patients that I had, they were on a wheelchair and unable to walk, but even some of the patients that have been treated early on, they need a walker at the age of 20, 25 to move around. So it is not a mild neuropathy, it is a severe one. The other thing, women who are heterozygous for this condition, but they have an infant with L-cell deficiency, they can experience preeclampsia. And what happens is that we believe that the hydroxylated fatty acid can flow back from the baby to the mom and cause this type of clinical presentation. In the cell content profile, you see an increase in the hydroxylated species, and then it is confirmed by DNA testing. Here, the therapy is difficult. You need to do fasting avoidance, MCT oil, triheptanoid. You need really to use a low-fat diet, restricting fat quite substantially in the diet. You might supplement with low-dose carnitine if there are low plasma levels. You monitor everything, and then you send to the heart and the eye doctor, because again, there can be significant problem. So far, we know cardiac arrhythmia, cardiomyopathy, there might be other complications that we still do not know. Keep in mind that the individuals that we have with this condition are barely 30 years old. We don't have people with L-cell deficiency who are 40 or 50 or 60 years old. And many of them, again, develop severe neurological complications. Mentality is completely normal. The prognosis is bad without treatment, but even with treatment, there are problems, muscle pain, retinitis pigmentosa, and neuropathy. Why is this so bad? It is bad because here what you have this reaction that can occur. So you have the formation of this 3-hydroxy fatty acid. And the body has never seen this 3-hydroxy fatty acid. So we believe that either the 3-hydroxy fatty acid or some metabolite, including possibly the fatty acyl-CoA of the fatty acyl-carnitine, might be toxic to this patient and be responsible for the pathophysiology. Now, how do we monitor therapy? The way that we monitor therapy, usually what you do, the therapy you give either triheptanoin or medium chain triglyceride, and you monitor the appearance of the medium chain acylcarnitine, C8, C6, sometimes C4, and in this condition. If you give triheptanoin, where there is the odd chain fatty acid, you monitor the appearance of C3 and sometimes C5. So obviously, this tells you that the patient is taking it and is taking enough. And finally, sometimes you see the presence of C4OH, which is hydroxybutyryl carnitine, which is the indicator that the patient can produce enough ketones to conjugate with the carnitine that tell you that you are providing enough substrate to limit fatty acid oxidation. Just a reminder, this can cause acute fatty liver of pregnancy or HELLP syndrome in women, and these are frequent in women who are carrier for this condition. So we are also called this enzyme trifunctional protein. In reality, there is a fourth function of this protein, and we do not know if it is related to the cardiomyopathy yet. But this is this function is monolysocardiolipin acyltransferase activity. And what it fails to modify cardiolipin. Cardiolipin, as you see here, it is this one with 4 legs. It is in the inner mitochondrial membrane, and we use it to make the curvature of mitochondria. You see how curved that mitochondria. Without cardiolipin, you cannot curve this one. So instead of placing 2 standard triglycerides here, you put the monocardiolipin here that obviously is narrower and allow the curvature to occur. So on the outside, you have more of the standard triglyceride. On the inside, you have some of this one that allow, that has less steric hindrance and that allow the formation of crystals. Now, what do we do when we have a cysteine OH elevated? You do the plasma isocarbonate with organic acid, and then if the results are consistent, you still proceed with genetic testing to distinguish between trifunctional protein and HL deficiency that have a slightly different prognosis. Now, we are doing in all of them this plasma isocarbonate urine organic acid, and then we do DNA testing. Why do we do this type of testing if then we finish doing DNA testing? The reason is that if this one is very abnormal, you start therapy immediately, even without waiting on the DNA testing. If they're very elevated, you want to start and get something done. Now, we have seen disorder of long-chain fatty acid oxidation. We have seen disorder of the carnitine cycle. Now, there is one condition which is called short-chain acyl-CoA dehydrogenase deficiency. And when we started working in the field, we considered this a disease. Now what we have found that this is pretty much a gene that has a function, but probably there are other enzymes that can bypass the lack of this enzyme. For these people, for this reason, we think that it is a benign variant, and we do not follow patients with SCAD deficiency. It is important, however, to identify this patient because we need to differentiate this condition from 2 other conditions that are called isobutyryl glycinuria and ethylmalonic encephalopathy. We do not know much about isobutyryl glycinuria, but we know about ethylmalonic encephalopathy. So this is what you see in the urine acylglycine, the urine organic acid in SCAD deficiency. In ethylmalonic encephalopathy, it is a bad disease. There is some therapeutic intervention that you can use, however. And what you can see an elevation of multiple isoglycine. Many dehydrogenases cannot work anymore. And you see a big elevation of ethylmalonic acid. You see that one as well in SCAD deficiency. But here, look at the lactic acid. Lactic acid is very much increased, ethylmalonic acid is increased, and you have the presence of elevated methylsuccinate, isobutyryl glycine, and 2-methylbutyryl glycine. So this is behave like a mitochondrial disorder, but again, there are some specific supplement intervention that. So what happened is C4 is elevated. C4 again is the marker of SCAD deficiency. You do the urine isoglycine, urine organic acid, urine carnitine, and the plasma isocarnitine profile. We actually don't do the urine isocarnitine here, so only the plasma isocarnitine. So, and then the result can be consistent with SCAD deficiency, isobutyryl-CoA dehydrogenase deficiency, or ethylmalonic encephalopathy. And obviously, we follow the one that have either isobutyryl-CoA dehydrogenase deficiency or ethylmalonic encephalopathy. The last condition that I want to cover today is glutaric acidemia type 2 or multiple acyl-CoA dehydrogenase deficiency. What this is a disorder of mitochondrial fatty and organic acid metabolism with the frequency of 1 in 100,000. In this case, the mutation impairs the activity of the electron transfer protein, flavoprotein. What does this mean? Let me go back a second, and I go back here. You see here, you have FADH2. Now, all of these dehydrogenases use FADH as their electron acceptor. So obviously, this needs to be regenerated. If it is not regenerated, this reaction will stop functioning. And this is done exactly by the enzymes that are defective in multiple acyl-CoA dehydrogenase. So these are the electron transfer flavoprotein, which is encoded by two genes, ATFA and TFB, and the ETF ubiquinone oxidoreductase, that it is called the ATF-DHG. So what happens is that you will be able to get the electron on FAD, but you will not be able to download them to the respiratory chain. As a result, the reaction, all of the dehydrogenases will stop working. And that is why you have, this one is called multiple acyl-CoA dehydrogenase deficiency, or MADD, in addition to glutaric acidemia type 2, because glutaric acid is one of the things that accumulate because glutaryl-CoA dehydrogenase doesn't work anymore. And you get the same symptom if you have riboflavin deficiency. The more severe form present in newborn, and these children are very dysmorphic. And they're dysmorphic because their brain does not form correctly. They have cysts in the brain. They might have cysts in the liver as well. Usually they do not last very long, and it is usually fatal. And then you have all degree of severity from just exercise-induced muscle pain to non-ketotic hypoglycemia, liver failure, cardiomyopathy, and a lot of other stuff. So depending on how much enzyme is left. And how do you diagnose? So here, the profile that they tell you on the website is elevated C4 and C5, but you know, the one that you see most commonly, they have elevated C10 and C12 carnitine. The urine organic acid are characteristic, but they can be abnormal only during the acute presentation. And you see the presence of 2-hydroxyglutaric in addition to glutaric acid. In glutaric acidemia type 1, you see the presence of 3-hydroxyglutaric acid. And then you do a DNA panel that includes all of the 3 genes and the gene that causes riboflavin deficiency that now are part of the panel. So, and some of these mutations respond to riboflavin supplement. The therapy is avoidance of fasting, prompt treatment of infection, low-fat diet, and riboflavin supplement. Again, riboflavin is a cofactor of the enzyme, and at high dose can function as a chaperone of the mutant enzyme. You might have to give a low-fat diet, ketone supplement. You can give ketone that they suppress the utilization of fatty acid. Ubiquinol. Most of these patients become ubiquinol coenzyme Q10 depleted, and that it is why you need to give ubiquinol, usually starting at about 1 year of age. They become carnitine deficient, and they have problem with essential fatty acids. You monitor the usual thing, and the prognosis is severe for the neonatal form. All other, we think they are okay, but we still do not know. We don't have a long-term course for all of them. So again, the problem here is in the transfer of the electron to the electron transfer flavoprotein, or in the subsequent transfer to the ubiquinol oxidoreductase. The isocarnitine profile can look like this. This is a neonatal variety. The long chains are the higher. In the common variety, C10 or C12 are really the highest level. The urine organic acid, you see a mess, and you see the 2-hydroxyglutaric acid, lactic acid, ethylmalonic, glutaric, adipic, subearic, and sebacic. So they reflect impairment not only of fatty acid metabolism, but also of many other reactions. Riboflavin deficiency can be caused by a mutation in a number of riboflavin transporter, or some of the enzymes that are required to insert the riboflavin in the electron transfer flavoprotein oxidoreductase. And one of these conditions is important, which is the Brown-Vialetto-Van Leer syndrome. And in this condition, you have neurological symptoms that could potentially be preventable by early therapy. In both conditions, in fact, high doses of riboflavin can reverse or improve the biochemical and clinical phenotype. So what do you do if you have elevation of, here again, they say C4 and C5, but many times it's C10 or C12. So you do the usual test, plasma isocarnitine profile, urine organic acid, urine isoglycine, and then you try to figure out if it is ethylmalonic encephalopathy, the one that you have seen previously with C4, or if it has to do with multiple acyl-CoA dehydrogenase deficiency. But remember to utilize the riboflavin metabolism disorder gene that mostly are disorders that cause riboflavin deficiency. Keep in mind that there is a phenocopy of MAD that it is called by injection of a toxin. This is one of them, but there are others. And sometimes there are epidemic of this one. Sometimes it is due to the fact it can be present in canned food. The last one happened in India. And this is called unripe key. So here it is present in Jamaica, but again, it is all over the world. So in summary, we have seen that inherited defects of the carnitine cycle and fatty acid oxidation can present at any age when energy from fat is needed, such as during fasting, infection, and fever. Patient can appear perfectly normal between episodes for which DNA testing is necessary. And remember to do a fatty acid oxidation panel with all genes, not just one gene. They cost the same, and the panel is way superior. Therapy requires fasting avoidance, low-fat diet, carnitine, medium-chain triglyceride, or triptanoid. Carnitine, in primary carnitine deficiency, you have low C0. In CPT1A deficiency, you have high C0. In CACT and CPT2 deficiency, you have elevated long-chain isocarnitine, C16, C18, C18-1, and C18-2. In MCAT deficiency, which is the most frequent, you have elevated C8 carnitine. VLCAT deficiency, C14-1 deficient is elevated. LCHAT, 3-functional protein deficiency, you have elevated hydroxylated species as C16OH, C14OH, C18OH, and C18-1OH. And SCAT deficiency, it is a known disease, but it is important in the differential diagnosis. And MET deficiency can cause a spectrum of phenotype, and you have deficiency of multiple dehydrogenases that obviously are responsible for the clinical presentation. I don't think we have time for questions. I want to thank all of the people at my former institution, and especially Dr. Pasquali, who has been the co-author of all of these slides. I would take question, but I think that next time I will have at least half an hour for question. I would reserve them for the next time with if it is okay with Dr. Baker. Thank you for your attention.
Thank you so much, Dr. Longo. That was an awesome and very comprehensive lecture. Any quick questions for Dr. Longo? You've gotten a couple compliments in the chat, people saying thank you. They'd had to leave a little bit early. No questions in the chat, but if anybody has any quick questions, yes, Dr. Judah.
Hi, really quickly. So I actually study inborn errors of cholesterol metabolism. And one of the things that I'm describing in patients with mevalonate kinase deficiency is actually complications with respiratory infections. And so one of the, I believe, I forget what it was, you're describing respiratory infections in
Yes,
your patients.
CPT1A deficient.
Yes. So
That-
I believe it's actually a manifestation of the surfactant in the lung, where the surfactant in the lung is actually tightly regulated with the lipid composition. So the composition between like phosphatidylcholine and like all fatty acids, this ratio between that and cholesterol is tightly regulated. And if that ratio is basically dysregulated, I believe it affects pathogen clearance. So I think that's a possible mechanism of how they are getting these respiratory infections. Because from what I'm seeing, patients with mevalonate kinase deficiency, they have a very high incidence of respiratory infections, and I think it's because of this. So I think that could be a similar mechanism of what's happening.
Thank you very much for the suggestion. I feel that it is. We still do not know how that happened, but it happened. So that it is a great startup. So what I'm going to do, I'm going to alert my colleague in Alaska. So if they have anybody who dies of it, I would ask them to get some lung tissue.
Please.
That is a very good suggestion.
So I'll give you my contact information. I'm seeing the same things. I was just presenting at the Genome Institute on Wednesday to talk about this. So it's very exciting of what I'm describing with this. But yeah, I'll keep in touch. Thank you.
Thank you very much.
Thank you. That was a great comment. One other quick question from the chat, and I'm just going to distill it a little bit. Do you have any differences in treatment between quote unquote severe MCAD versus not severe MCAD or those with residual enzyme activity? Is there any distinction by genotype?
The only distinction is that many with the milder MCAD, I don't give carnitine supplementation, but all of them are at risk of sudden death. So the difference that in the severe MCAD, you might crash. Let's say that you are an adult, you might crash after 24 hours. In the milder MCAD, you might crash after 36 hours of fasting. So that it is the difference, so that you are a little bit less strict. But I treat all of them because I like people alive. And the treatment is preventing fasting. Man, what kind of heavy-duty treatment is that one?
Yeah, no, that is good, and I think that's pretty standard. The other thing that we get a lot is questions about dietary therapy, and we typically don't use dietary therapy for MCAD.
Exactly. So we leave them alone.
Yep. Wonderful. Well, thank you. We're a little bit over time, but thank you, Dr. Longo, for sticking around. Thank you, everybody else. Next week, we will have, I believe it's Dr. Longo again, talking about carnitine metabolism, ketone metabolism, and some extensions from this lecture, along with time for some questions at the end. So thank you so much, and everybody have a good week. Thanks, Nicola. It was great seeing you again.
Thank you. Bye-bye.
Bye-bye. Also, keep in mind if you are looking for a faculty position, Dr. Longo has some openings.
Yeah. Email me. Thank you.
Thank you.
Bye-bye. Bye-bye. Bye-bye.
Bye.